Good afternoon, everyone, and thanks for joining us for today's Healthline 3. I'm Johnette Magner. This is a program where we like to focus on ways to live a healthier and a happier life. And we're going to be taking your calls, and our doctors will be answering your questions live in studio today. We'll be opening the phone lines in a minute, but as a reminder, please make sure you're in a quiet room when you call with your TV turned all the way down. Otherwise, you'll hear some delayed noise. Our number, 318-219-4569. And joining me now from Willis-Knighton Eye Institute is Dr. Christopher Shelby and Dr. Weish Coleman. And you all are the eye doctors.
We are, that we are.
More specifically, the cataract surgeons.
The
cataract
surgeons.
surgeons. All right, so let's talk about cataracts. Something that I actually learned a little bit about with Dr. Shelby.
You learned quite a bit, actually.
All right, so start by defining a cataract.
You know, it's just a clouding of your natural lens that occurs over time. Everybody will get it. All you got to do is live long enough. The average age of cataract surgery in the U.S. is about 69. Some people need them when they're older. Some people need them when they're younger. Sort of a continuum. But when it's bad enough that you don't see as well as you need to, even with your best glasses prescription, that's typically when it's time for cataract surgery, assuming that there's nothing else going on with the eye causing vision loss.
So how do you know, you've got glaucoma, you've got macular degeneration, you've got cataracts. How do you know when you need to come in and get one of those checked out? And how are they different? How is the cataract problem different from the others?
You know, everybody gets cataracts. I mean, that is one thing. It's a reward for birthdays. You know, it really is. As you get older, your lens goes from crystal clear to yellowish brown. And so you'll have these natural changes over time. You know, you hit your 40s or so and you lose your near vision. You gotta wear readers. You know, most people, it's interesting, that'll be the first time they ever come in and see the eye doctor because they're like, oh my God, I'm going blind, something's wrong. And these are just natural changes. And then the glare at nighttime, there's typical symptoms. And most people hear about cataracts because somebody in their family's had it done. And so very, very common. Something like glaucoma is a disease of screening, okay? Meaning that it's painless. The vision loss it causes is permanent. We can't get it back. And so that's something that we screen for during an exam, which is why it is important to get routine eye exams, especially over the age of 50. You know, some would say 40, but 50 is very important. Macular degeneration, of course, is just wear and tear on the center of the vision and the very back of the eye. And that's something that's also picked up during routine screening exams. And if somebody has a family history or has a high risk of having that, it's a good idea to come in, you know. But that's a loss of central vision.
All right, so you said people should come in and be screened. You know, I think about those people I've long envied. I had glasses in second grade who have just perfect vision. But and then as they begin to age, it declines. But if you haven't had to go and have your vision screened before because you haven't had an issue, how often should you go and what age again?
You know, probably everybody should go every couple of years. I don't think it's necessarily a yearly thing, but if somebody's perfect and has no problems, but you definitely want to go in and get seen at some point with an eye doctor. So there's plenty of good ones around. You know, that's a pretty easy screening exam. They check pressure, look at the optic nerve. Glaucoma is easy to diagnose, but I think glaucoma is the most compelling reason to see an eye doctor on a regular basis, even if you have no problems.
So somebody has a cataract, what can you all do for them?
All sorts of stuff, you know. Obviously, when somebody comes in and they're correctable to 20/20, we tell them, hey, you have a cataract. We're just letting you know. Because they can usually brew over years before they get bad enough to take out. And so when the symptoms get bad enough to where it's affecting the quality of life, then it's time to have cataract surgery. And so with cataract surgery, you know, our preoperative screening is in depth because we look at every aspect of the eye that can affect visual outcome. And then based on that, we can make recommendations for what type of lens. You know, a lot of people just opt for the standard lens, which is optically perfect. You know, it's great. It allows generally great distance vision, but you can't read with it. Gotta wear readers. And if you have any astigmatism, it doesn't correct that either. And so, but you still see much better than you did before. You just gotta wear glasses. So the glasses you get actually work. And then there's lenses that we can put in that allow distance, intermediate, and near vision without glasses. You know about those. And then we have, and those are great, those are wonderful. And then we've got light adjustable. I mean, the list goes on and on and on as far as which lenses we can put in. You know, and somebody who's had RK, we can put the light adjustable lens in to allow them to, to really manage their focus after surgery. We have a really cool one called the Apthera. It's the IC8 lens, and people who have really diseased corneas, scarred up corneas, they're irregular, and it's usually high cut RK patients who never really refracted to 20/20, and it is a pinhole lens, so you put the pinhole up there and everybody's like, oh wow, I can see so much better. Well, in certain patients, putting that lens in, it's actually, the change is amazing of what they can see. So, it just all depends on what we find during the preoperative assessment.
And you had it done, is that correct?
I did. I had this right eye done. I didn't know who I wanted to do it. I'm just kidding.
I worked my way to the top of the list.
He did work his way to the top of the list.
The price was right.
It was funny because we talked about it. This is pretty funny. We talked about it, I don't know, about 5 years ago, because the symptoms were, coming on, and he was sitting there. He's like, well, because I wasn't going to go to anybody else. And he was like, well, give me about 10,000 more cases, and then I'll be ready to do it. So about 5 years later, I was like, okay. Actually, he called me.
Oh.
And said, you want to do that pre-op? I said, yeah, let's do it. And I think he didn't expect that to happen.
No, I didn't expect him to show up. So he showed up, and it worked pretty well, though. It was a high pressure day.
No, it worked perfectly, actually.
So I believe we have a caller right now. Robert, welcome to the program. What's your question for our doctors?
Yeah, what kind of treatments are there for macular degeneration, dry macular degeneration, besides the vitamins? Is that all that's available?
That's a good question. That was a topic we were going to cover later today. And so that's a common question. Dry macular degeneration, there traditionally has not been a lot of things to do for it. The vitamins help some. They did a big study, maybe 30,000 or so participants, and if someone smoked, stopping smoking made a big difference in outcome. The risk of vision loss went way down. Taking the specific vitamin formulation, Preservision, Ocuvite, the AREDS 2 formula is what they call it. That's what they used in the study. That slows the risk of progression a little bit. Now, there is, so I think it's worth doing. There is something called red light therapy. That's a new device that delivers a specific wavelength of red light to the retina that slows progression and can gain a little bit of vision back in people who have macular degeneration. If it's already profound vision loss, it's really not going to do much there. But if it's early, that can reverse some, and that exists now. And there's a couple of places in town that have it. We don't have one yet. We thought about getting one. But it's all cash. Insurance doesn't cover it yet. I think they probably will at some point. I hope they do. But that is something that can be done. And I believe Dr. Baber's got the equipment to do that. It's worth seeing him. I've sent a few people for him for that. Seen some good results, but it's sort of a long-term thing. So that is one more thing that can be done to slow progression, and that's worth looking at if you've got dry macular degeneration.
Okay. So I look on computer, Facebook, and all, and it shows all that stuff about vision, something, some kind of pill you take.
Right.
Is that just a hoax?
No, that actually helps a little bit. So taking Preservision vitamins is one of the only things you can do. So I think it's worth doing. If I had macular degeneration, I would do it. But at this point in time, I'd also be looking closely at that red light therapy. I think that's probably a good option, and I think that's probably going to improve as time goes on.
So who do you say does that?
Dr. Baber, Wilson Baber, he's a retina specialist in town, and if you see us, we can refer you to him. But he's a good guy, does a good job with the retina, and he does have the piece of equipment to do it. So that's an interesting thing with macular degeneration that's sort of on the forefront.
Okay. So I have to call y'all, go through y'all to get to him.
Not necessarily. You can just call him directly, or you can come see us. Whatever you want to do, be glad to help you.
Okay. All right.
Thanks for the call.
I appreciate it.
Yes, sir.
Thank you, Robert.
Okay, so back to cataract surgery, and we've alluded to it, but I just had it all done with you, and wait, Piers, we have another caller. Welcome to the program. What is your question for the doctors?
Yes, this is Chief Red Elk, Dr. Shelby. I know you remember me.
Oh yeah, how you doing, buddy? Sure
Been
do.
quite some time ago. You did cataract and PRK on me.
Right. I remember.
And,
Yeah.
Yes, y'all were so good to me, and I am so happy with my surgery. I'm about to be 79 now.
Wow.
I still read without glasses most of the time. If it's really tiny, I use glasses. I was almost blind when I came in.
Yeah, you were.
I could drop a coin on the floor and I'd have trouble finding it. And you guys worked a miracle for me, Doctor. I appreciate y'all so very much.
You are very, very welcome. You're the reason we love our job, and I tell people that we have the best job ever, and you've done great.
Let's clarify for the viewers, you're not a paid caller.
Yeah, no, yeah, exactly.
Or a
You
family
did not.
member.
That's right.
Let me say this. The VA sent me over there. I'm an old Vietnam vet, and recently, in 24, I ended up on chemo, and I was having some vision problems. But after that, it started clearing back up again, and I am just having a great life. I read constantly, and I just love life. And you guys gave me a miracle.
Wow, doesn't get any better than
Doesn't
that.
get any better than
No,
that.
it really doesn't. Thank you so much. Good. Glad you're doing well.
Well, thank you. I'll get off and let some real serious people call that need to call. I just needed to tell you what I appreciate and how great you guys did for me.
Absolutely. Thank you so much for the call. Appreciate that.
Yes, sir, Dr. Shelby. Y'all have a great day. Bless y'all.
Thanks, you too.
You too. Yeah, he. I remember his case very well, and we took his cataract out, a dent. I mean, rock hard, and then ended up tuning it with photorefractive keratectomy, which is similar to LASIK, except LASIK you have the flap, but with PRK we have to brush the surface of the eye because there's some irregularity also, and it works wonderfully well. The problem is that it takes a little time to heal. It can be uncomfortable for a few days. The vision fluctuates for a few weeks or months. But the ultimate outcome is amazing, and you have to reassure patients, and he's delightful, by the way. I mean, he's a great.
Yeah.
We enjoyed him in the clinic. He was just really, really delightful. So, anyway.
Well, one of the things that I think surprised me so much was I really had no pain at all with cataract surgery. Is that common, not to have pain at all during or after?
Yeah, that's the rule. Anything else would be the exception.
Yeah.
Sometimes people feel a little burned, but the thing is, the eyes at the beginning, but the eye is very easy to anesthetize, so it's easy to get it numb, and after that, you don't really feel anything. So there's some burning. You've been to the eye doctor's office; they sometimes put numbing drops in. It's about like that. Once you get the eye numb, there's no pain after that, and that's an advantage of the eye, is it is very easy to numb it.
Which is not what you would think. You get an eyelash in your eye and you're
Right.
so uncomfortable.
Yeah.
But I found that so truly amazing. And the other thing too, really quick recovery time. Talk about cataract recovery, please.
Yeah, you're going back to the no pain and the recovery. when I had it done, I wasn't brave enough to not get any sedation, but I didn't want too much because I wanted to remember the whole procedure, and I do. Didn't feel a thing, and when I got home, I wasn't sure what to expect. Things were a little foggy, a little hazy, but no pain. And we send patients home with a shield because we don't put stitches in, and so you have to wear a shield at night, which I did. I was actually pretty compliant with that.
Unbelievable.
I know it is amazing, and you wear the shield at night while you're sleeping, just for 5 nights, because that way you don't bump or rub your eye. And then the drops. That was I have empathy. All of my patients now, because the drops for a week, you're using 3 of them, 2 of them 4 times a day, and then after that first week, I tapered down the steroid. Now we do have Dextenza, which is a canalicular insert of dexamethasone where patients don't have to be on the steroid, and so that's convenient if it's covered. But it's not bad. I mean, literally the next day, most people, kind of like you probably experienced, you wake up and you're like, okay, You know, I mean, and you know, you're expecting something that's not there, other than the fact that you can see better.
Yeah, I think the hardest thing for me was just remembering to take the drops.
Right. Yeah, same.
You know, it's because you do take them for a while, so you have to put little reminders on your phone, but that's a very small price to pay for good vision at all distances now. I've, you know, after I came in, had it done, I've never pulled my glasses out again. Reading glasses, anything. Is that really common? Is that people don't have to use them at all?
That's the typical result, and that's what most people are looking for. You know, and a lot of people come in, they are there to see us specifically because they want to become glasses independent. That's the mainstay of what we do. You know, and I have patients come in, they say, I have friends who got cataract surgery, they had a multifocal lens, they don't wear glasses. I want the good lens. That's what I'm here to get.
The good lens.
And I say, well, you know, that's a little bit of a loaded question because before I look at all the preoperative measurements, the corneal topography, the biometry, the retinal scans, it's the best lens for a particular person may not be the best lens for another person. So the important thing about cataract surgery is the process that we use for planning it and to determine how do we get to maximum glasses independence and maximum visual quality in that particular eye. So, you know, people sometimes say that I was here for longer than I thought. I did a lot of testing. I think I may have never had an eye exam before compared to this, because we do an extensive series of testing, but that gives us a complete picture, because then we can say with great certainty, this is what you are the best candidate for. And some people aren't a great candidate for a multifocal lens, and the best choice for them is just to get a good distant target and plan to wear readers to see up close. That's the case for some people, but we do try to get glasses independence to the maximum degree possible for both distance and near. But that's a process of planning. So we've got excellent screening tools. I think we have the best diagnostic equipment in the world. We certainly have the best equipment in the OR, and we talk about it a lot, but we don't talk about the screening process as much. And that's the key thing, is to say, let's make sure that we put a lens in that's going to work the best for that given eye based on the objective testing that we get preoperatively.
While this process is, you know, we think of choosing our doctors, the reality is that we spend even more time with your staff, interacting with Miss Lee that I worked with, and your staff is incredible. They're so attentive. They know your name. They tell you how to get them if you're having any kind of issues. What is the culture that you try to build with your staff so that your patients get the attention when they need it, but not necessarily from you all?
Yeah, you know, the staff, you're only as good as the people you surround yourself with, right? And so we try to select, you know, the best people, but generally what will happen is, you know, they come into our practice and they kind of share our joy as far as the results that we're giving. And we allow them to share in that joy. And so now Lee, I'm going to tell you, she's been doing this for 45 years. She started with Dr. Steen when she was like 18 years old, I think.
Yeah.
And it's like, I think she's forgotten more about different refractive surgery than him and I'll ever know. And but she's great, and she's very patient with patients, and that's very important, you know. And but it all, you know, it comes down from the top, and so we love what we're doing, and it comes through in our staff.
We do have a great staff. I mean, I have to say that. Like, it's hard to find good people these days, and we've got a lot of good people. The other thing is, we do a lot of training to make sure that they have a good understanding of what's going on, so that and we bring them to the operating room so they can see what's happening after they leave the clinic. You know, in that, because otherwise they would just see them when we work them up, and then we see them when we come back. But try to bring them, let them come to the operating room and see what's actually happening, and then relay to them. We got some training programs that we built for the staff so that they have a good understanding of what lens option is best for a particular person. That way they can answer some of those questions that are on a high level. They're all ophthalmic technicians at different levels of ophthalmic technician, but then we do specific training for our cataract surgery and refractive surgery staff so that they have a very good understanding of it. And a lot of them in our office have had surgery themselves. So that's helpful, because then they really understand the process. They've done it before. And, you know, now we've even taken that to another level with Dr. Shelby having had cataract surgery. So that sort of helps the whole program for everybody to understand what's going on, especially when they do from a first person perspective.
But you haven't had it.
I'm not. I'm only 46, so hopefully 45 still for a
Hopefully
little
you'll
while.
need it.
Hopefully I'll need it. Hopefully I'll live long enough to need it. That's what the hope is. I'm about to need readers, so I'm getting more empathetic for people who have to wear readers. You know, the near vision. I would probably 10 years ago was more apt to say, well, just go for distance and wear readers to see up close, but it's a little bit worse than I thought it was going to be. So I think that drives me more to say, let's really think hard about how we can leave you completely glasses independent, because I'm not liking the readers. I need them only in the afternoon in low light right now, but you know, give me a year or two, I'll have them in my pocket all the time. I can see it coming.
Yeah, and I'm gonna to that point. You know, when I had it done, you know, we have such good results, because the most common question I get, they're like, well, what'd you get? What lens? And I said, look, you know, in this right eye, because I haven't had the left eye done yet. I'm, you know, letting him relax a little bit before I jump on the table, for his sake. You know, I was like, okay, I'm going to go for a good distance target, and I thought I was going to need a toric lens to correct any astigmatism. And the reason being is because my cataract was from trauma. When it's traumatic, the lens bag, the bag that holds your natural lens, can be a little bit unstable. And a multifocal lens, if you put it in an unstable bag, it'll decenter, which isn't conducive to good vision. So I was worried about that. We talked about it. And matter of fact, after surgery, he's like, you know, the bag's okay. And so we just went ahead and put in the distance lens. I've never seen this well at a distance. And based on the preoperative testing that we did, you know, he's like, I don't think, we're looking at the images on the computer. He's like, you know, I'm like, okay, it doesn't look like I need a toric. And I didn't. And
That's a good example of the objective testing driving the plan, you know, because he actually thought, you're going to put a toric lens in mine, correct my astigmatism. And I was like, of course, he had never done the full workup. And I said, before we do this, we got to do the full workup, like in my office where I can look at it right there and to make a decision. So I don't think you need a toric lens to correct astigmatism. And he didn't. He turned out 2015. So that was good planning leads to good results.
That is impressive.
Yeah, amazing.
If somebody wants to get in to see you and go through all this process, what kind of wait time do they have? How much time does it take to get in to see you guys?
Not long, especially for cataract surgery. You know, we try to keep our schedule open. That's the mainstay of what we do. So we try to make sure that we're not pushing that out months. It would be within the month for sure. If someone just cold called the office, if they do, say you saw us on TV, you'll get in within the month. And then we don't delay surgery too much. We've got a big capacity to do cases up at Willis-Knight, and you know, we don't usually get backlogged with some people have a limited amount of operating room time. Ours is almost unlimited. So if we have a backlog of cases, we can just put more surgery days on. So, and we keep the clinic open specifically we have designated spots for cataract evals. So quick, I can get somebody in within a couple of weeks, and then we can do surgery within a couple of weeks after that, typically.
Well, I didn't know if I was just special or if that was the case
you are
for everyone.
You're special.
I mean, you are special.
Yes.
Yes.
Normally it's 6 to 12 months.
Yeah, but for John Ed, it's like, you know, I mean, like 3 days. But yeah, we try to cater because that's what we love to do, and you know, and we have a lot of colleagues that help with the process too. And so, Dr. Coleman and I aren't burdened just with all of it, you know, and our colleagues are great. So,
and cataract surgery, you know, that is the mainstay of what we do. We need to add up the total number. I remember the old billboard that Steen had up that said over 50,000 cataract surgeries performed. This was up when I was in my 20s, and I was like, well, that sounds like a lot to me, you know. You know, but Shelby's surpassed that now. He's in the 60,000 range. I'm probably in the 30,000 range, without giving an exact number. It's somewhere between 25 and 30. But between the two of us, we're coming up on 100,000 total cases done. We do about 5,000 a year. So that's one of the reasons for the experience too, is everyone is on board. Like, that is what we do. We don't just do a little bit of that. Like, that is what we do. So the program's real set up for that, and everybody's very familiar with the process.
Well, that's what we've always heard about when you're choosing a doctor. Choose one who does it all day, every day.
Yep.
You want somebody who's done it many, many times. Let's talk about macular degeneration. Elaborate on what that is and how you know if you are perhaps suffering from it.
You know, macular degeneration, the technical term is age-related macular degeneration. And it's wear and tear on the macula, which is the very center of the vision, because that's one of the most metabolically active places in the body. You know, a lot of blood flow, a lot of turnover of cellular material, and you get these deposits in the macula called drusen. And the drusen, that's what we see on exam. It's like, hey, you have early macular degeneration. It usually takes a while for it to cause any visual problems. Now, dry macular degeneration can progress into wet macular degeneration. What that is where, because there's a thinning of those layers, the blood vessels behind it there's a signal called VEGF, which is released to allow more blood vessels to come through. Well, those blood vessels break through and they bleed, of course, hence the term wet. And if that happens, it causes a dramatic loss of vision, centrally, you know, just in the center of the vision. You know, the whole eye doesn't go blind, that's a totally different thing. And so now if that happens, we got to see you. And then usually, you know, our retina colleagues, like, you know, Dr. Baber, Dr. Lyon, Dr. Gosley, they do injections.
Don't forget Kavanaugh.
And Dr. Kavanaugh, our buddy Dr. Kavanaugh, sorry, at LSU, yes. And I know it's crazy, there's only 4 of them in town, and they're all awesome. But the injections are amazing how well they work. I remember when I was a resident, we didn't have injections yet, and they would do PDT, which is photodynamic therapy. And that's where the girls would hook up an IV, they would inject a medication inside the eye, and then literally have a stopwatch, and then shine a light on the eye, you know, with a lens. And what it was supposed to do was stimulate that chemical to release a bunch of free radicals, more or less, that then destroyed those blood vessels. Really didn't work all that well. And so then, you know, they would have to put a blanket over themselves, like a big towel, because it reacts to the sun also. It was crazy, but I mean, you know, what you could do. And I remember Dr. Baber and I, when I was a resident, we went in and we used to go in and he would remove these little networks of blood vessels from underneath the macula. And that was a big surgery. And so with the injections, it was a revolutionary thing. But with dry macular degeneration, it's generally asymptomatic, you know, and it's usually picked up on during an eye exam. And so, but it in of itself can cause blurred vision. And you know, geographic atrophy, that's another form of macular degeneration, which is just like a big scar that extends from the center of your vision. And that's kind of the coup de grace of what do we do about that, because there's really nothing we can do, and it just progressively gets worse and worse over time. Injections don't really work for it, you know, and it just, the vitamins are okay, but they really haven't been studied for geographic atrophy like they have for the dry macular degeneration.
But there's some new stuff in the pipeline.
Yeah.
The red light therapy seems like it's pretty
very
good.
helpful.
And this affects our cataract surgery planning some too, because if you want to leave someone totally glasses independent with something like a multifocal lens, you need a totally normal retina. So there's a lot of times you have somebody come in that says, you know, I have friends who got the multifocal lens, I want to get out of glasses, and when you do the exam, you can see macular degeneration. Even though it's not affecting the vision much, it may affect the visual quality afterwards, and the best choice could be just go for a distance target where readers to see up close. So that's something that affects our cataract surgery planning too. It's the reason we get a good look at the retina, scan of the retina before we do cataract surgery, so we can make sure that it's normal before we go and promise someone a result that's unattainable. So we try to be realists about what's possible based on the exam.
And cataract surgery is covered by most insurance?
Correct.
Yes, if it's significant, it's covered by Medicare and insurance.
Okay, so how can people find you all?
Our website is thecataractsurgeons.com, and my office number is 212-5901.
Mine's, well, our Portico Piermont location is 212-3937, and then of course north is 212-2020. So whatever's most convenient for patients, we have a location there.
All right, well, it's been a pleasure to talk with you all today, and actually to be your patient as
Yeah,
well.
you were great.
I have no glasses.
I know, you were wonderful.
I'm happy.
You were
yes.
Another
you were a
happy
wonderful,
customer.
compliant patient, much more compliant than me.
Okay, thank you. And thank you to all of you for joining us for Healthline 3. Have a good afternoon.